I'm Sherry Wilkie. I serve on the management team at Mountain States Genetics Regional Network, and I'm here to welcome you today to the session on adding value to pharmacogenetics. And I have the pleasure this morning of introducing you to Dr. Abdallah Elias, who's the medical director at the Department of Medical Genetics at Shodair Children's Hospital. So please reference your screen for CEU accreditation and disclosure statements, as well as the CEU tab in the attendee website. And Dr. Elias, we look forward to your presentation.
Great. So I hope my screen is being shared now. And well, thank you for, I guess, for tuning in, so to speak. And it's a real pleasure to be here at the MS-RGN Summit today. And I actually was able to look at some of the presentations yesterday, which I think were excellent. So it's a lot of fun. Well, today I will present a collaborative project between Shodair Children's Hospital in Montana and the University of Montana to bring you really the topic of pharmacogenetics a little closer. So I will talk about the project, but really my main concern here is to kind of get you a little familiar with pharmacogenetics. The project itself is aimed at making pharmacogenetics or pharmacotherapy safer, and really doing so by leveraging pharmacogenetics through a delivery model that is designed to address the specific needs of rural communities in Montana. And because Shodair's primary focus is behavioral health, the emphasis will be on the model for pediatric behavioral health. So I have no disclosures. And the first part will be an introduction where I hope to give you a basic understanding of what pharmacogenetics is about. And then in the second part, I will outline our current efforts to implement an integrated model of pharmacogenetic testing and consultations for inpatient and outpatient psychiatric services at Shodair Children's Hospital. So we'll go over the promises and basic principles of pharmacogenetics and ask how can we use genetic information to improve patient care by optimizing the choice and the dosage of medications. We will look at the scientific evidence in support of pharmacogenetics, but also its limitations. We will look also at the clinical utility and ask whether using pharmacogenetics brings benefit to the patient and improves outcome. And then we'll ask at what cost any benefit of pharmacogenetic-guided therapy actually comes. So we start with a clinical vignette to become a little familiar with some of the terms that are important in pharmacogenetics. So in this vignette, you will hear about clopidogrel. The trade name is Plavix. So clopidogrel is an antiplatelet agent that together with aspirin is used as a standard dual antiplatelet therapy after coronary artery stent placement to really reduce the risk of the coronary artery to close again, which is called restenosis. Now, while this is not a medication obviously used in psychiatry, it has a well-established FDA labeling with regard to pharmacogenetic testing, which is why I'm using it here as an example. So you will hear also the term prodrug. A prodrug indicates that this drug is inactive at the time of administration, requiring a conversion or a biotransformation into a pharmacologically active drug after it's administered. And so this activation is done by a drug metabolizing enzyme. And in that regard, you will hear the term poor metabolizer, indicating that the drug metabolizing enzyme involved is in either the activation or degradation. In this example, it will be activation. But in general, poor metabolizer means that the drug metabolizing enzyme is either inactive or sometimes not made at all. So you will also hear the term genetic polymorphisms, which are DNA sequence changes common in drug metabolizing enzymes that contribute to individual variability in enzyme activity and then consequently cause individual variability in drug metabolism, and through that variability in response to certain drugs. And then lastly, you will hear about CYP, or you will hear the term, I guess, CYP2C19, CYP2C19, which is one example of a cytochrome P450 enzyme, which is the most important group of drug metabolizing enzymes in the liver. And although there are many other pharmacogenetically important drug metabolizing enzymes and other drug targets, we will limit our discussion today to the group of these cytochrome P450 enzyme or drug metabolizing enzymes. So this is our first vignette. So this is a 65-year-old male with coronary artery disease who underwent elective percutaneous coronary angioplasty, or PTCA, and stenting, so stent placement, using a drug-eluting stent. Now, as it is standard, dual antiplatelet therapy was initiated with clopidogrel as a loading dose and then followed by maintenance therapy. However, after 2 months, he noticed palpitations during exercise, and those turned out to be ischemia-induced arrhythmia on stress testing. Now, recatheterization showed an in-stent stenosis, a restenosis of 90%, and the lesion was retreated with another drug-eluting stent. So clopidogrel then was discontinued and replaced by another platelet inhibitor, ticagrelor, similarly with a loading dose followed by maintenance therapy. And he had normal stress testing after 6 and 12 months of intervention and has been doing well. So what's going on here? Well, clopidogrel inhibits platelet aggregation. It is, let me put my laser pointer here. It is, however, a prodrug, and that must undergo activation into an active drug. And that activation is through drug metabolizing enzymes of the cytochrome P450 group. Now, individuals who are poor metabolizers due to a genetic polymorphism have reduced ability to activate clopidogrel and are therefore at increased risk for stent thrombosis. Now, specifically, and this is shown here at the lower panel, the CYP2C19 genotype, the genotype of this enzyme, or the gene that encodes for this enzyme, impacts the efficacy of clopidogrel in patients undergoing stent placement. So the question then arises, should the cardiologist, in this case vignette, have ordered pharmacogenetic testing prior to elective stenting to determine the patient's metabolizer status and perhaps by that reducing the risk for stent thrombosis? Well, the FDA has issued a black box warning for decreased antiplatelet effect of clopidogrel for patients who carry loss of function alleles in the CYP2C19 gene. Now, from this information, you would think, well, yes, perhaps the cardiologist should indeed have ordered pharmacogenetic testing prior to stent placement of this patient. However, the reality is much more complicated, and we don't have time to go into details regarding the different polymorphisms, their corresponding metabolizer status, and then the different frequencies in different ancestral backgrounds, although those are important considerations in this decision. But suffice it to say that genetic polymorphisms account for really only a minority of the variation of platelet inhibition by clopidogrel in stent patients, with other factors collectively explaining actually much more of the variation. So despite the FDA black box warning, the current evidence-based recommendations do actually not include routine pharmacogenetic testing in patients undergoing coronary stents. Now, the clopidogrel boxed warning then leaves the issue of whether to perform CYP2C19 testing up to the individual physician, and it doesn't specifically require genetic testing, nor does it actually imply that there is any solid evidence to do this. And the reason why I say this, the level of evidence here is all level C, which is not very high level of evidence. So this exemplifies the difficulties to navigate decisions on when and how to use pharmacogenetic testing in clinical practice. So what is pharmacogenetics? Well, think about the traditional way of prescribing, which is based on large, it's kind of shown here on the top, large clinical trials that derive really an average dose for a hypothetical average patient. And this is shown here in the lower panel, and in contrast this with pharmacogenetics, which is the study of how an individual's genetic profile of certain genes, in this case, the drug metabolizing genes, how these influence his or her response to drugs. And then the promise of pharmacogenetics is that it can improve patient care by optimizing the choice and dosage of medications with the goal to decrease adverse events and increase desired effects through what sometimes is also referred as personalized medicine or precision medicine. Now, here's an illustration of this concept. When you give the same dose of the same medication to a group of patients with the same diagnosis, you will find that some will have no benefit and no toxicity. So you'll just, this was just, this has essentially no benefit. Then you have some that actually have benefit and actually have minimal or no toxicity. And this is really the group you want to target with this drug at this specific dose. Do have also some individuals who have benefits. They do have therapeutic effects, but they do have significant side effects. And then you have those who have no benefits and no toxicity. And significant toxicity. So you will find all of these. And really the goal of personalized medicine through pharmacogenetics then is to identify those patients who will respond with a beneficial therapeutic effect to a given drug with a minimum of side effects. This is the group here. So success and what is it? And minimal side effects. However, you also want, of course, to find those and to know about those who will not respond or who might respond, but who might have excessive side effects with standard dosages. So for some of those patients then who do not respond well to conventional drugs and dosages, this may result in either a change of the standard dosing or others may benefit from alternative drugs. So each patient then has his or her individual drug response profile. And that may be influenced by, the drug metabolism, the body's drug metabolism, drug transport, or drug receptors, for example. And for the purpose of this presentation, we will be focusing on pharmacogenetics of drug metabolism only. Now, this drug metabolism is through enzymes, as I mentioned, which either activate or deactivate the drug. And then the activity of drug metabolizing enzymes varies, with some of the variation being caused by genetic variation in those genes that encode these enzymes. So this is shown here. So the effect of the genetic variation for drug metabolizing enzymes on drug response depends then essentially on two things. Number one, whether the drug is a prodrug, requiring activation, or whether it's administered already as active form. And then the second factor is, the big factor, is whether the genetic variation leads to either decreased metabolic activity or increased enzyme function. Now for active drugs, here shown on the right side, that really need to be metabolized to inactive drugs to be cleared from the body, those genotypes that result in decreased or perhaps absent enzyme function can result in increased drug plasma concentration and therefore increased risk of toxicity. Whereas those genotypes that increase metabolic activity, they can result in subtherapeutic drug concentration because it's cleared too quickly and therefore the risk of treatment failure. Now it's essentially the opposite for prodrugs. Those genotypes that result in reduced or absent enzyme function can result in decreased concentration of the active drug because there's just not enough enzyme there to activate the drug. Whereas those genotypes that result in increased metabolic activity, those can lead to increased concentrations of the active drug. Too much active drug is made too quickly and then increased risk for toxicity. So the most important group of drug metabolizing enzyme is really represented by that cytochrome P450 enzyme system in the liver. And there are over 50 genes in the human genome that encode information for these enzymes. However, only a few are medically important. And so the members, and those are shown here, the members of the CYP1, CYP2, and CYP3 families are really the most important ones. And those are responsible for metabolic clearance in the liver of around perhaps 3/4 or so of drugs that are metabolized in the liver. Now, by reading the genetic information for these enzymes through DNA analysis, we can identify common changes found in the population, and those are called polymorphisms. The pattern of genetic polymorphisms defines the genotype. Now, depending on the effect of these polymorphisms and the resulting genotype, the phenotype, which is essentially the enzyme activity, can then be normal, decreased, or increased. And so here are the different drug metabolizer phenotypes based on their pharmacogenotype. And in general, poor metabolizers, which is shown here on the right side, poor metabolizer phenotype refers to those individuals who have two complete loss of function alleles, each on a different parental chromosome. And this is indicated here in this graph here by the two crossed out boxes. And then we have this large group here of individuals who are extensive metabolizers. And extensive metabolizer refers to the normal phenotype, which is usually the most common in the population, which as it is shown here, and is usually seen in individuals who have at least one or two functional alleles, is shown here in these orange boxes. There is an intermediate metabolizer phenotype, which may have allele combinations that result in various degrees of impaired enzyme function. And there might be actually overlap with the normal extensive metabolizing phenotype. However, there is this other extreme group here, the ultra rapid metabolizers, who, and that's caused by gain of function variants, for example, in individuals who actually have multiple copies of the functional gene, as shown here by three boxes. So based on the genotype, then the metabolic activity of enzymes can be predicted with most individuals in the population being extensive metabolizers, and only, however, a small group, but a significant group of individuals being either ultra rapid metabolizers or poor metabolizers. Now, it is important to realize that the frequency of this some important variation across these pharmacogenes can vary strikingly by ancestry, with the result that certain ethnic groups may be at unusually high risk of displaying unusual or abnormal drug responses to specific drugs. And unfortunately, those are often groups that for which we don't have as much information. So the predictive power, if you will, for pharmacogenetics in these groups until we have more information is unfortunately not as good. So the idea of pharmacogenetics then is to genotype individuals for their drug metabolizing enzyme activity, and based on the genotypes, predict the individual risk to either have no benefit, or increased toxicity for a given drug. Now, this is a busy slide, but there are really essentially two messages here. This is really goes towards, what's the evidence for pharmacogenetics-guided therapy in psychiatry? And I have to say that using pharmacogenetics in guiding drug therapy in psychiatry still leads to discussions as to how robust the data for its clinical use really are. This is shown here in the middle column. This is really in part to a relative scarcity of high quality randomized controlled trials with sufficient power to provide a robust basis for sound recommendations and guidelines. And as you can see, here that until recently there were quite small. The cohorts that were that these studies had were actually quite small. It's not until recently that larger numbers of patients have been included for studies in psychiatry. However, and this is shown here on the right side, overall the data does support that genotyping leads to a higher response, higher remission rates, and better tolerability. Now, implementation of pharmacogenetics in routine care also requires demonstration of cost effectiveness. So in this systematic review here from 2017, the authors looked at economic evaluations for drugs with existing pharmacogenetic labeling by the FDA. And they looked at the proportion of evaluations that found pharmacogenetics-guided treatment to be cost-effective or even perhaps cost savings over alternative strategies. And then they did something interesting. They also estimated what the impact would be on this proportion when you remove the cost of genetic testing. And that last step, removing the cost of genetic testing, makes actually sense. And the reason for it is that there is just vast or significant variability of the cost for pharmacogenetic testing in different settings, with, for example, cost in the US being generally much higher than in other countries. And so what they found is they found about 44 evaluations that they thought were worth further evaluation. And there, among those 44, they found 57%, here in blue and in orange together, 57% drew a conclusion that was in favor of PGx testing. And of those, 30% were cost effective and 27% were actually even cost saving. However, if they remove, if they basically, modeled if genetic information was available at no cost, then actually 75% of economic evaluations would support pharmacogenetic-guided treatment. And of those, 25% would be cost effective and actually 50% would be cost savings. So I think we can overall say that not only is there an increasing evidence in support of clinical utility of pharmacogenetic testing, but there is also mounting evidence of cost effectiveness of pharmacogenetic testing. Now, there are many challenges of implementing pharmacogenetic testing. One of them is just the limited availability of pharmacogenetic-guided dosing recommendations. And the Clinical Pharmacogenetics Implementation Consortium, or CPIC, as well as its corresponding European organization, the Dutch Pharmacogenetics Working Group, those are international consortia that have published and continue to publish guidelines for multiple drug gene pairs, really focusing on the question of what might be an appropriate dose adjustment given the availability of genetic data. However, the CPIC really does not address questions of when and how pharmacogenetic testing should be done. And we are interested in evaluating how pharmacogenetic testing can improve mental health care in Montana. So mental illness, as you all know, is a major health issue and has great individual and social economical impact. And addressing this crisis is particularly difficult in Montana's youth affected by mental illness and due to the limited number of psychiatric and behavioral health professionals, few behavioral health facilities for children and adolescents, and really the vast geographic distances with about 90% of Montana being designated frontier areas. So clinical utility of pharmacogenetics in psychiatry, to address that, it's worth to kind of look what the current landscape actually is. And here we have to say that perhaps about 30% of patients who suffer from psychiatric disorders remain, only about 30% remain compliant with their medication and really reach stable remission. About 50% with major depressive disorders do not respond to their first antidepressant, and about 25,000 patients in the US present to the ED every year due to antidepressant-induced adverse events. And a major factor for these side effects, as well as the lack of efficacy, is the relationship between the dosage and the systemic exposure to the drug, which can be approximated by the serum drug concentration. And this is really where pharmacogenetics comes in, because we think that about 40% of the variance in patients' responses to antidepressants may be due to variations in drug metabolizing genes. Thus, pharmacogenetics may actually have particularly high clinical utility in psychiatry, as psychopharmacotherapy is really hampered by these side effects and difficulties with efficacy or effectivity. So equipped with this knowledge then about pharmacogenetics, we'll now switch gears and talk about an integrated delivery model we are currently in the process of implementing in Montana. And so we'll start again with a clinical vignette to illustrate why interpretation of pharmacogenetic test results in psychiatry may be challenging and may be best accomplished in the context of an integrated consult service. So this is a 19-year-old female who presented with generalized anxiety disorder and panic disorders. She was stable on 30 milligrams of escitalopram, but developed a rash, which is not uncommon with that medication. And then she was transitioned to fluoxetine, which, by the way, is primarily metabolized by CYP2D6. So she was able to tolerate 20 milligrams of the medication, but really her symptoms didn't improve. They did a few other things. I think they added buspirone and added clonazepam for the panic symptoms, but really it didn't improve her symptoms. And then fluoxetine was increased, and however, she then developed nausea, vomiting, and fatigue, and those side effects persisted. So she had then pharmacogenomic testing, and that revealed a poor metabolizer status for CYP2C9. We don't see that at all here, but also an ultra-rapid metabolizer status for CYP2D6, which, and as I mentioned, CYP2D6 is one of the major metabolizing enzymes for fluoxetine. Now, we will get to that, but she was started then on Venlafaxine, which, by the way, also is primarily metabolized by 2D6. Venlafaxine, however, works well for her, and she's stable on 150 milligrams and is doing well now. So, the question here then is, so the patient's anxiety was not controlled with low-dose fluoxetine, yet she developed side effects after a modest increase in dose to 40 milligram daily. So the question is, does the rapid ultra-metabolizer status perhaps explain her lack of response to fluoxetine because she's cleared too quickly? But if that's the case, why then doesn't she tolerate a moderate dose of fluoxetine, which has a maximal daily standard dose of 80 milligram? And then furthermore, with venlafaxine itself is extensively metabolized by CYP2D6. And so why would we start her on this medication when the pharmacogenetic test report just told us that the patient is a 2D6 ultra-rapid metabolizer and therefore at increased risk for treatment failure? So the answer is a little bit more complicated, and we'll get back to it after outlining an integrated pharmacogenetic consult model, which may be helpful in this situation. So this is the pharmacogenetics implementation project as a collaborative effort. And the participants here are the Shodair Outpatient Services, which is an outpatient center that provides psychiatric care for children, adolescents, and young adults. Then the Shodair Inpatient, the psychiatric inpatient program, offering intensive services for children and adolescents. The Shodair Genetics Laboratory, in this case, providing the pharmacogenetic testing. Then the University of Montana Precision Medicine Project, which focuses on pharmacogenomics, emphasizing really on rural and underserved populations. And at last, the University of Montana Department of Pharmacy Practice, which houses clinical pharmacists who have advanced training, including in psychiatry and behavioral health. And we really believe that pharmacists are ideally situated in facilitating the implementation of pharmacogenomics into the mainstream clinical practice. So here we have the components of the implementation project on the left side, the clinical care services on the right side, the testing lab and the pharmacy consultant service. And so ideally, Upon admission to the acute, frequently the acute in inpatient psychiatric service, the provider reviews the patient's medical history, the medication intolerances, medication list, and recommends perhaps pharmacogenetic testing. That includes also explaining the purpose of the test, what kind of data is collected, and then also to obtain an informed consent. And then the patient, or perhaps more commonly the guardian, considers then the pharmacogenetic testing. And if the patient or guardian consents to the testing, a buccal swab is sent for pharmacogenetic testing together with a consult request. So that is kind of integrated. The testing is integrated with a consult request. The genetic lab then initiates the pharmacy consults that includes securely transmitting the patient and physician information to the pharmacy consult service, and then the lab completes the testing, issues a pharmacogenetic test report to the pharmacist and then the consultant, the ordering physician. And then the pharmacist takes over, updates the medical information and the medication list, reviews the pharmacogenetic test report, creates a personalized pharmacogenetic consultation and discusses that the therapeutic plan that is in this case then guided by the pharmacogenetic test results with the ordering physician. And then there's also documentation in the EHR system. So really, with this, because this is an integrated system where patients usually step down to a residential unit and they may then be followed through outpatient services and continuity care, there's really the opportunity for longitudinal assessment with the physician documenting the clinical course and the pharmacist then helping to adjust the PGx-guided therapeutic plan as needed. And so we believe that such an integrated consult model can improve an important pillar of behavioral health, namely psychopharmacotherapy, by adding value to pharmacogenetics this added value really derives from multiple sources. I think using pharmacogenetic data smartly and competently, increasing medication safety through systematic review of pharmacists, avoiding polypharmacy, and really creating a continuity of care with respect to medication therapy. So at last, let's resolve our clinical vignette then. And to remind you, we were wondering why the patient developed side effects on an only moderate dose of fluoxetine, despite being a 2D6 ultra rapid metabolizer, and why we chose to put her back on anti-anxiety medication that is also metabolized primarily by 2D6, and she's doing well with it. Well, so fluoxetine is not only extensively metabolized by CYP2D6, but fluoxetine itself, as well as its metabolite, are also potent inhibitors of CYP2D6, which can sometimes potentially override the rapid metabolizer status. And this is probably what was going on, partly what was going on here. Now, on the other hand, while 2D6 is also the major metabolizer, amazing enzyme in the first pass for venlafaxine, its metabolite, desvenlafaxine, is not metabolized by 2D6. And itself, actually, desvenlafaxine has itself pharmacological activity. Thus, it takes, so venlafaxine is, so it's not surprisingly desvenlafaxine actually works well in this situation. So, I think you really have to do a detailed review of the complex metabolic pathways and the drug metabolite, as well as the drug-drug interactions, to fully leverage pharmacogenetic information in a meaningful way. And we think this is best accomplished through an expert consultation with a pharmacist in an integrated system. So I hope that this last example illustrated that an integrated model of pharmacogenetic testing and consultation can help leveraging the full potential of pharmacogenetics in clinical practice. And so with this slide, I just want to mention some of our team members and collaborators. Erica Woodall, she's a professor at the SCAC School of Pharmacy at the University of Montana. Haley Blackburn, she's a PharmD assistant professor at the Department of Pharmacy Practice at the University of Montana. Corbin Schwanke, our lab supervisor and administrative director. Josh Loveland, clinical pharmacist, and Jackie Piazzolla, who's a molecular biologist scientist in our lab who has done much and is still in the process of doing kind of the hands-on work for the pharmacogenetic platform validation. So with this, I'd like to thank you for your attention and I guess open it up for discussion after, let's see, stop sharing.
Okay, I would like to encourage y'all to enter your questions in the Q&A tab on the attendee website. And Dr. Elias, while we wait for questions to come in, would you, is there anything that you weren't able to cover that you would like to?
You know, I not necessarily, there are certainly things we can expand on that I couldn't include. I do see a couple of questions.
Yes, there is. Why is there so much focus on phase 1 processes in pharmacogenetics, but little focus on genetic differences in phase 2 processes like sulfation, glucokination, and malylation, for example?
Yeah. So, you know, that's a good question. And that kind of goes to the limitation that I actually, that I had here with this talk. I really focused on, and as you correctly mentioned, this is let's see, a question by let's see, who was this? Like Susan Owens asked that. So Susan, you're absolutely right. So the the CYP, the CYP450 enzymes I mentioned here are part of the phase 1 the phase 1 mechanism. Now there are many other potential targets, including other metabolizing you mentioned, for example, glucuronidation, which is important really for renal excretion. And those, there is focus on those as well. So there are pharmacogenetic tests that you can, and polymorphisms in those genes that are involved that can be tested and are being tested. In addition to phase 1 metabolizing processes, there are, so when you look at phase 1, what Susan really mentioned is here the pharmacokinetic part of pharmacogenetics, meaning that how is a drug, once it is administered, how is it distributed in the body, how it is metabolized, where it is metabolized, and how it is excreted then. And those are all pharmacokinetic questions. However, in addition to those, there are certainly also our pharmacodynamic targets, if you will. There are a number of genes that are increasingly being considered here. For example, HLA-related antigens, which are important in the in adverse reactions such as inflammatory allergic reactions. For example, abacavir is an HIV drug that is associated with a high level of 50% essentially of patients who have a certain HLA B phenotype or genotype, a polymorphism, are at a high risk, 50% risk of developing a severe skin reaction, the Stevens-Johnson syndrome, for example. I mentioned citalopram earlier in one of the patients who had this rash. This rash reaction can also be associated with this. There are other drug targets, pharmacodynamic, so that really targets that are important not so much for the drug metabolization, but the drug effect. Those are certain receptors, for example, serotonin receptors, opioid receptors, and for example, the catechol O methyltransferase is also an effector enzyme that can be and is being included in pharmacogenetic testing. I just did not have really time to talk about this. So that's certainly one of the reasons.
Okay, I think we have time for one more question, Dr. Elias. Could you please explain further those patients who fail to respond to a drug but still get side effects? If a patient clears a drug too fast to gain therapeutic outcome, would they also quickly clear out the risk of side effects?
Yeah, so that is a question that we cannot always answer, but that you are right. This let's see, I think I can see this question. This was from Sarina Kopinski. Great. So And maybe let me the last example I gave. So there are a number of reasons why this can be. Let's say we have a rapid metabolizer. Based on the serum concentration of that first initial metabolizing step, the serum concentration in this ultra rapid metabolizer should be low. So the therapeutic, as you said, there's no response to the drug, there's a treatment failure, the risk is high. But some patients may still get side effects, and this can have different reasons. One, I kind of touched a little bit on that last example. Sometimes the drugs that are metabolized are also inhibiting that enzyme. And in different individuals, that balance can be different, so that actually even at low concentrations, you can have an adverse effect. Another possibility are pharmacokinetic independent side effects. For example, allergic reactions or inflammatory syndromes. I mentioned the HLA-related Stevens-Johnson syndromes that can be part of it. So the problem is that there's a multi-layered and sometimes redundant system, which really puts limitations on the predictive value of any pharmacogenetic test results that we will get. And it becomes even more difficult if a drug, for example, if a drug might, if you test several drugs that might be actually included or important in the, if you test several enzymes that might be important in the metabolizing activity of a certain drug. So if you have that to interpret those results of two different pharmacogenes related to a certain drugs can be very tricky, and the evidence for that, that to make decisions is sometimes not very high, so it can be complicated.
Thank you, Dr. Elias, for a very informative presentation.
No, well, thank you. Thank you for having me.